Hi, this is Samantha Lishtak, owner of Absolute EHS. We are here today with retired Lieutenant Andrew Haber, and we're going to talk about personal protective equipment changes for medical first responders. So, Lieutenant Haber, would you mind telling us your credentials before we delve in?
Sure. My name is Andrew Haber. I retired from New York City EMS, part of the New York City Fire Department, back in 2016. I started in 1991. 1990 or so, I became an EMT through a continuing ed program at Brooklyn College. A couple of nights a week, took a class and got certified as an EMT. Put my application in with New York City EMS back when we were with Health and Hospitals Corporation. Got hired on, worked as an EMT for about two and a half years to get some field experience, touching patients, getting used to those types of calls. Went for my paramedic training through EMS, passed, became a paramedic in '94. Worked as a paramedic in the field in Queens, Brooklyn, and in Staten Island till 2005. 2007, I'm sorry, 2007, where I took the promotion to lieutenant, uh, became a lieutenant, which is a field supervisor in EMS, worked in Brooklyn again, and then ultimately spent the last 10 years in the Bronx when I retired in 2016. Uh, I also volunteer with the Slate Hill Fire Department in Orange County, New York. I've been their EMS captain for a little over 10 years now. And since my retirement, since I have what I always refer to as a limited skill set, I've continued working as a paramedic per diem for a local ambulance company, putting in a couple of shifts a week, covering the Orange County area. Been a CPR instructor for American Heart Association, first aid instructor, stop the bleed instructor. I've taught for Office of Emergency Management, their CERT program, and had a deployment with the incident management team for the FDNY during Hurricane Sandy.
And
And
you did some work during 9/11 as well, right?
I was a responder during 9/11. I was working actually the first time the World Trade Center was attacked in '93 and spent time dealing with patients then. I was working on 9/11 and spent time as part of the recovery effort subsequent to that. And yeah, pretty much anything else that happened in the city in that time frame, we were involved with in some extent.
Wow. Okay. So you're the perfect person to have on this interview. I wanted to talk about changes in personal protective equipment protocols for emergency first responders. So what did you need to do on a normal call before COVID hit versus what do you need to do now that COVID is everywhere, especially in New York?
Uh, Traditionally, when we would ever go into calls, our main concern was always bloodborne pathogens. Specifically, worrying about AIDS, HIV, hepatitis, and we always had gloves on. It was a standard, and whenever we did training, all the new EMTs, whenever they came in for skill, they go, "I have gloves on, PSI, and body substance isolation." And it was just gloves. That's how we isolated ourselves. And that came from the big AIDS scare, we'll say, back in the 80s. Before that, a lot of healthcare providers in the pre-hospital didn't even have gloves. We still did mouth to mouth. That's changed. We don't do mouth to mouth. We would use a bag valve mask or some type of barrier device. We would, whenever we were dealing with blood or body fluids or anything like that, we always had gloves on. That was how we kept ourselves safe. Back in the later years of my career, we definitely had issues with SARS, with avian flu, swine flu. Ebola was a big scare for us down in the city for a while. We were worried about it. On the different flu ones, we would take isolation precautions. You know, if the patient, said they had something or we suspected, you put a mask on. But it wasn't every call.
What type of mask?
In the field, we would pretty much only wear N95 masks.
Okay, so you all got fit tested and trained.
We were fit tested and fit retested every year as part of our training. We would go for our annual medical, and as part of our annual medical, we were fit tested. We got the appropriate size N95. We would put it on. You had to be clean shaven, no beard. Get a good test, put a hood on. They would spray, usually I believe we use Bitrix solution, and read the rainbow passage, which was a classic for all of us.
Still the
And
one we use.
could smell the Bitrix solution. If you couldn't smell it, those molecules weren't getting past the mask. It was properly fitted. And properly putting it on, donning and doffing, once a year in training for 25 years, made become second nature. So when you really did need it, when you had someone who had something that was potentially airborne, it was easy to put on. When we had the Ebola scare, we had specific hazmat crews that would put on more evolved, like level A PPE to go deal with those patients. We would identify the patient and bring those crews in. So not every crew would have to deal with it or put that level of gear on, but we all did learn how to put on higher level of gear in case we did need it, in case that became a pandemic, and thankfully it did not.
Right. And just to clarify for anybody listening, level A is the full encapsulation with a supplied air canister on your back.
Right. Most people learned, I believe, we were doing level B, which was, without the air canister, N95, full Tyvek suit, tape wrist and ankles, the whole 9 yards. So it's good training, and thankfully, like I said, back then we didn't really need it for the majority of our crews. But now that we have an airborne pathogen going on with COVID, it's definitely come in handy knowing what to do and how to wear things properly.
So before we were saying that we primarily wore gloves when we went to a call, mostly for bloodborne pathogens. Now that we've got potential COVID patients, what do you do? What do you ask to know if your patient, if you're running into a home that might be contaminated with COVID-19?
Well, we work with the assumption before we walk in the door that there's a potential. So the first thing I'm going to do is I'm going to start with my very basic layer. If I don't know, very often our dispatchers would tell us the patient's COVID positive. When they do the call screening, they'll ask, have they been exposed to any COVID patients? Do they have a cough, fever, travel out of the country? And if they've already been tested and they tell us that, yes, I'm COVID positive, well, then I'm going to put an N95 on. I have a face shield I'll put on, gloves, and I'll start with that. I may even put a gown on, depending on what's going to be wrong with the patient. If it's, I'm going to have to give the patient a nebulized treatment, if they're an asthmatic or if they're having a problem breathing. I don't want to do that in a closed ambulance anymore. Normally, if you're having an asthma attack, I'll take you in the back of the ambulance, give you a nebulizer, go to the hospital. We don't want to do that because when I'm in the back of an ambulance, I'm in a 4x6 box that's pretty well sealed up. There is a vent, but it's only going to move so much air out at a time. And as you're bringing in a nebulizer, you're breathing out any other particles that come with it. I don't want to breathe those in. I don't want to get them on my clothing. I don't want to get them on my hair, or my eyes, anywhere. I don't like taking my work home. So for those situations, we're going to put on a lot of gear, and being gear is getting used frequently. So like I would say, if I go into a regular patient, someone with chest pain, I may just start off with a surgical mask. And then when I go through the questions a little more involved, have you been sick recently? Have you been running a fever? Do you have a cough, a dry cough? Have you been exposed to anyone? Have you been out and about? Have your family members been out and about? And I get that picture. If I think that this may be COVID related, potentially, then I'll switch up to an N95 mask and start putting on more stuff. If we get ahead of time that it is a positive patient, then I'll walk in. Like I said, I'll have gloves on. We don't have as many surgical gowns or Tyvek suits as we used to. So adapt, improvise, and overcome. And one of the things we found works very well is a rain poncho.
A rain poncho.
Rain poncho. It's meant to be a barrier for moisture. It's plastic, pretty well solid piece of plastic. We get the ones that have the elastic on the wrists, and they have a little elastic hood. So I have the hood. It's going to come down over here. Works as a bonnet, covering the head, shoulders, down to my arms. put on nitrile gloves. And because I have old habits of doing this stuff back when we trained for Ebola and a lot of other things, I tape my wrists. So I know the glove to the gown or the poncho is a complete piece. Tape both my wrists, and the poncho is coming down to at least my knee level. So I know that I got coverage there. From that point, put on an N95 mask, protect my nose and mouth and my respiratory. And then I have a head shield that brings the visors down, covering here. So again, creates another level of barrier to keep any possible aerosolized particles away from me. It takes a little more time than just putting gloves on, but it's how I keep myself safe. And ultimately, it also helps keep the patient safe. Because as a first responder, I'm going to many different patients' houses over the course of a day, course of a tour. I'm going into the hospital where there are COVID positive patients, COVID negative patients, trying to keep my exposure limited, but there's always possible that I have an exposure. I also need to go out and do food shopping occasionally and the other activities of daily life. They're very limited at this point, but they still happen. So if I come down with it, whether or not I show signs and symptoms of it, and then I'm going into patients' houses where they're potentially sick with other problems, if they have cardiac issues, respiratory issues, diabetics, any of the myriad of problems, they have comorbidities. I don't want to be the one to bring COVID to them on top of their other issues. So it takes a little longer, but it keeps me safe, and hopefully it helps keep them safe as well.
Is there additional PPE that you put on your patients now that you wouldn't have otherwise done before?
Normally, it was always PPE was meant to protect the rescuer,
Yeah.
first responder. We put it on because you had the issue. You were calling because you had a laceration. So this was your blood. You weren't worried about your blood, but I'm worried about your blood. So that's why we had the gloves. Now that we have this going on, we put masks on everybody. So if the patient is COVID positive, they get a mask. If they're not COVID positive, they get a mask.
Surgical mask.
Surgical mask, yes. Because we don't know if they're COVID positive or negative sometimes. And if I'm taking them into the hospital, there's obviously other healthcare providers in the hospital and a whole host of other patients. So the mask is really to keep in whatever they have. It will help to a point of transfer from somebody else to you, but really what a surgical mask is for, surgical masks were meant to protect the patient from the surgeon. So if you're wearing a surgical mask, it's protecting everybody else from you. When I wear it, like I said, if I'm heading out to the supermarket, I put it on because this way I know I can't infect anybody else. If I happen to have something, it's keeping everybody safe from me. Everybody does that, keeps it all in, that's good. N95 mask keeps me safe from you. It's a little, different way of thinking. So if I have to go to a doctor's office, or if I'm going to donate blood or get blood work or anything like that, I'll wear a surgical N95 mask, because it's a greater population in a smaller space like a doctor's office, and there's a potential that someone may have something. So I'm not as worried about transmitting to them. Now I'm worried about them transmitting to me. So I'll try to wear a higher level of mask then. But 99% of the time, if you're going out and about, a surgical mask, it's like I said, it's me protecting you. It's me doing the right thing.
So for the general public, most people are not trained or fit tested in wearing N95s. A lot of people have comorbidities that might even have them fail the physical associated with getting into an N95 or any kind of advanced purifying respirator or APR. How do you feel about these fabric masks, these cloth homemade masks that some of your patients might be wearing?
If you know the limitations of what you're wearing, then it's okay. If you think it's the savior, then it's not. A cloth mask, homemade mask, a bandana, it will work similar to the surgical mask in that it's going to keep particles from coming out to some extent. If you put on a bandana and you go spray paint on a wall and you're in that environment and you take that bandana off, you're going to have spray paint around your face because those molecules will get in. But if you pin bandana on and try to spit through it, it's not going to be very effective. So if you think that the bandana is going to save you, no, it'll save other people from you. Same way the surgical mask will. It is less effective. They're not made to be as tight fitting as a surgical mask. Most of the time when people are wearing surgical masks, there are gaps around the side or down in the chin. But again, it's not to keep the air from coming in, it's to keep your air from going out.
Right. And with your spray paint, just illustration really quickly, we usually spray paint, we're worried about volatile organic carbons or VOCs. Neither a surgical mask nor a bandana is really going to do
Right.
much against that.
No, it's more the fact that the paint molecules will make
Oh,
their
the
way.
paint, yes. Okay, yeah. Okay, so if you were to get a patient who was wearing a cloth face covering of some sort trying to be helpful, would you switch it out for a surgical?
Usually we do, only because I know the surgical mask is clean. It came out of a box. I know the standard that is. The cloth mask that they're wearing, well, some of them are very fashionable. I'll be the first to admit that one. Much more fashionable than our surgical masks. I don't know when was the last time it was washed. I don't know what other exposure this mask has had. So very often in the house, I'll say, let's do you the favor and let's leave that mask at home, because the last thing we want to do is lose it. We'll put on the surgical mask for now. And most people are more than happy to.
Okay. So another thing that we see a lot is medical first responders, doctors, nurses, I think even morticians, they're pitching tents in their garages to protect their families, or they're stripping down as soon as they get home, putting everything in the washing machine because they're nervous, and rightfully so. With all of the new procedures and your rain poncho and all of that, how confident are you that you're not bringing anything home?
I'm pretty confident. I have I'll say the privilege of being what we call a fly car medic. So I work alone most of the time. I am assigned a vehicle and I'm the only one in the vehicle. I have no partner. So I don't have to worry about any cross contamination there. First thing I do when I show up to work is I clean the vehicle. I spray it down with a cleaning solution that we have that is meant to kill COVID-19. So if someone used the vehicle overnight and didn't clean it, I clean it top to bottom. I clean every piece of equipment that's assigned to me, wearing my gloves, wearing a mask. Everything gets sprayed down with the appropriate time. Some chemicals we use are 2 minutes, some of them are 10 minutes, and then we wipe it clean. Then I get into the vehicle. Radios, dashboard, everything's clean. So now I know I have a safe environment for me. I go and sit in my area, and I wait till I get a call. When I get a call, I get out of my vehicle, and I'll go into the ambulance at that point. And that's when my exposure level starts. And if we have suspicion of a patient being COVID positive or having symptoms that may lead us to believe that, I put on all the gear. And now I know I'm in my little safe cocoon. Take care of a patient, take him to the hospital, come back out, take everything off in a prescribed order that we do it in, so we make sure we don't contaminate ourselves. Put on clean gloves and a mask. After I've taken all the masks and gloves off, I put on brand new ones, and then I go through the cleaning process again. I clean all the gear that was involved with that patient. The crews will clean their ambulance. I will go clean my vehicle now. Not the entire vehicle as I did before, but the steering wheel, the dash, the gear shift, the radios, because someone else drove my vehicle for me usually. One of the EMTs will take my car and drive it to the hospital. And not that I don't trust our EMTs, I do 100%. I love working with them. But I don't know what their exposure level is on a day-to-day basis. So once again, the vehicle gets cleaned. You become very rigorous and religious about doing these things. It takes that level of worry down a lot. So I'm limiting my exposure. I'm limiting the environment that I'm in. So when I do come home, the first thing I'll do, I'll take my gear belt off. My boots stay out in the garage. If I have any exposures that I'm concerned about, that clothing will go right into the washing machine, get washed separately. If I need, obviously, take showers right away and everything. And also have a spray pump of hand sanitizer that's almost straight alcohol, it seems, some of them. And I get sprayed down any equipment that I have to worry about with that and wipe it down and leave that out in my garage.
Right. I think that's the World Health Organization recipe. That's 80% alcohol is what.
It very well may be.
Yeah, I've got some of that too. It's pretty powerful stuff. So another question I've been running into is, with all of this extra cleaning, how much time are you adding to your day? And on top of that, with all the extra PPE you have to put on before you help a patient, do you feel that your ability to get to a patient in a critical event has been compromised?
I wouldn't say it's compromised. It does add some time. The time it adds to it, the day, I mean, we work for a 10 or 12-hour shift, and you can only see so many patients in any window of time. So if I'm not going to that call, someone else is going to call. And here in Orange County, our call volume is less than, let's say, back in New York City, where I used to work. And New York City was swamped. They had an incredible call volume when this first kicked in, and they called for help from all over the country. And the response they got was phenomenal. In the pre-hospital setting, EMTs and paramedics from all over the country showed up with their ambulances and crews and did a phenomenal job. Call volume is less in Orange County. The population is less. So I don't know that we've really had any delays in calls. We do have a very good timely response. But when I show up to a call, it will add a couple of minutes to put on the appropriate gear. But I can do a lot of things from a doorway. So if I come to the door of somebody's house and open it up, and I can start asking questions from 10 feet away, 12 feet away, plenty of distance. So I can start getting a history, because a lot of what we do is going to be question and answer. What's going on? Where's the pain? How long have you had it? What other medical problems you had? What exposures have you had? What medications you on? What allergies to medications you on? Does anything make the pain better or worse? And as I'm doing that conversation, I could start adding on more gear.
What if it's a cardiac, a massive bleed, something that we're always taught in emergency response to immediately address because it could be between life and death?
Well, if it's one of those things, safety still has to come first, and it's the crew's safety that we need to worry about, because if we get sick, we can't help anybody in the future. Uh, if it is a massive bleed, let's say, traumatic amputation, the 911 dispatcher will give whoever calls information on how to start the process of stopping the bleed. If they're in cardiac arrest, the dispatchers will give them CPR instructions. So care can happen without us even there. We will have bystanders do whatever they're willing to do via phone instructions. And again, I can put a mask on en route to a call. I keep, masks in one pocket and gloves in another pocket. Now, I can't take my hands off the steering wheel to put gloves on, but realistically, it does not take me that long to put gloves on. If I know going in, before I even grab my equipment, I could start putting stuff on. And, again, I'm an old fogey at this. So after 29 years, I've kind of learned how to dress myself quickly.
I'm proud of you. Great. Well, those are all my questions. Is there anything else that you as a first responder would want the general public to know if they need to call 911 or otherwise need to take care of themselves or protect themselves?
The main things that we always like to tell people are, if you need 911, please call. Don't hesitate. If you are showing signs of a heart attack, chest pain, feeling of impending doom radiating down your arm, any of those things, showing signs of a stroke, slurred speech, facial droop, any of those things, please call. We will take care of you, and we will get you to the hospital in a safe manner, and we will protect you from the other patients in the hospital. We don't want to bring you to the hospital so you can get sick. On the other hand, if there's something wrong with you, and it's something that does not need an emergency room, that's what we have doctors for. That's why there are urgent centers. We want to save 911 for true emergencies, life-threatening emergencies that need an ER. If you're not sure, we never have a problem with you faulting on the side of calling. You can make an informed discussion at that point and say, you can go to an urgent center for this, but if you'd like, we will take you to the ER. We will always be happy to take someone to the ER. And that's it. And we just hope everybody stays safe, and we will get through this.
Great. Well, thank you so much for joining me today. I really appreciate your time.
Glad to be here.
Great. Thank you.